but today's putting more meat on these bones anyway, so we are going to reinforce these concepts, but I just want to highlight a couple things about this slide. What are we looking at? What is filleted open in this slide? The right atrium, exactly. So these pectinate muscles and this crista terminalis are things that are found in the right atrium. There are also pectinate muscles in the right atrial appendage or auricle, right, and in the left auricle, but not in the left atrium. Okay, we're going to get to that. We're going to get to that. I just wanted to bring it up. But I wanted to put a better picture of it because, as I said, it is the dividing line between the auricle and the smooth wall of the atrium, but it's also the dividing line between the rough anterior wall of the atrium, the right atrium, and the smooth posterior wall. If you look at this, crista terminalis, you can clearly see this smooth area right here, the right atrial appendage, that's going into the right auricle, and then the remainder of this then being the right atrium, right, the anterior wall. Does that make sense, everybody? Sure? Okay. And then papillary muscles, we're going to discuss those in depth today because we're going to talk about the valves. Chordae tendinase, same. It's just the attachment to the valve cusps from the pectinate muscle, or the papillary muscle, excuse me. And then trabeculate carnate, only in the ventricles, help slightly increase surface area and muscular contraction strength. Just specialized band of myocardium that have a unique coverage on them. All right? So just wanted to go back over those things real quick because I think I might have gone a little bit too fast, especially for the first day. So here we are. Now we're going to go a little bit more in depth, or I should say a lot more in depth about the chambers of the heart. All right? Right atrium, what flows into it? The vena cava. Anybody else know what else flows into it? Anybody else in any other structures?
The other vena cava.
Both vena cava, right? Inferior and superior, but anything else?
Coronary sinus.
Coronary sinus, that's right. And then some of the cardiac veins, right? Some of the cardiac veins themselves are into the coronary. So we have most of the deoxygenated blood in the body returning to the right atrium, all right? Everybody knows about the vena cava, but the coronary sinuses, stuff like that. So posterior wall is smooth, as I said before. Anterior wall has those pectinate muscles, right? As does the appendage. So if you see, remember I said yesterday everything's got to have 2 names or 3 names? We're going to go through that a lot today, unfortunately. But we're going to tie it all together and make sure it all makes sense. So right atrial appendage, right auricle, same thing, okay? Same thing. Intra-atrial septum, what does it sound like it does? It's not ironically named. It separates the atria, right? Okay. And then the tricuspid valve, all right? Let me make this valve stuff easy from the get-go. There is only one bicuspid valve. There is only one valve that only has 2 leaflets. It's the mitral valve, otherwise known as the bicuspid valve, all right? All of the other ones, pulmonic, aortic, and tricuspid valve have 3 leaflets. So the easiest thing to do is, if you're ever confused, is remember the one thing that's different, not the 3 things that are the same, right? Study the differences when you're studying. Memorize the short list, not the long list, all right? So if you're going through this, we're going to see bicuspid valve, mitral valve, semilunar valve, aortic valve, pulmonic valve. We're going to tie it all together, but the thing to know anatomically is only one of them has 2 leaflets, okay? Easy enough to start? All right. So the tricuspid valve is the entrance to the right ventricle from the right atrium. Right? Okay. And tricuspid valve. This one also not ironically named because it has 3 cusps. Looking at this, all right, we can see the crista terminalis, this time in English, terminal crest. Right? Also got to know Latin for some reason. Okay. Right ventricle. And then what is a common name for the mitral valve and the tricuspid valve is the atrioventricular valve, right, as they go between the atrium and the ventricle. So you see here, atrioventricular valve, that's the tricuspid valve, okay? So like I said, 7 different names. As long as you know where they are, what they look like, it's easy. It's a lot easier than anatomy books make it for some reason, okay? Oval foramen, we'll talk about that in fetal circulation very briefly. What that should be labeled in a adult heart or in a neonatal heart, that post-term, somebody who has been born, is fossa ovalis. because the foramen ovale is a patency that goes between the atrium in a fetal circulation, because the fetal circulation is slightly different because their lungs are filled with fluid. So most of their oxygenated blood comes from the placenta and the umbilical artery, right? So once that closes, it becomes the fossa ovalis. And what does fossa mean? This is like a divot, right? It's like an indentation, okay? Right ventricle, not super, I want you to note the thickness difference between the right and left ventricle specifically. The atria are all pretty skinny because the atrial systole, the atrial kick that actually forces blood into the ventricles is not that substantial. Most of what drives the blood through the atrioventricular valves is pressure and weight of blood, not necessarily forceful contraction of the atria that are kicking that blood into it, all right? Actually, atrial kick is late after the valve's already open. We'll talk about that later. Anyway, 4 to 5 millimeters thick. Why do you think that is? If I were to tell you that the left ventricle is about double that.
Doesn't have to get
Yeah, lower pressure system. Right side is a lower pressure system, right? So what are we pressing against into the left ventricle basically, let me just start over. The right ventricle just has to get the blood to the lungs, right? Left ventricle has to get it everywhere else with sufficient force to make it around. Right? So much thicker chamber, although in a normal human heart, both sides eject the same amount of blood. Now, if we start to get pathophysiology, anybody ever heard of hypertrophic cardiomyopathy? Then you start to get a thickening of that left ventricular wall. That space gets smaller and smaller, which means less blood is coming out. All right. So we already talked about trabeculate carni, right? Chordae tendinate and papillary muscles. So 3 papillary muscles for the tricuspid valve. That makes sense? Each cusp has its own muscle. Fair enough? Easy. And then the chordae tendinae are what actually physically connect the muscle to the valve leaflet itself. Let me go back to this. The moderator band, this guy right here. So does anybody know where most of the electrical impulse activity, where are the pacemakers in the heart generally? SAWAV, where are they physically? Right side, yeah, right? So even in the right ventricle, the bundle branch has a specialized band of trabeculate carni called the moderator band that helps electricity travel into the bundle of his. Anybody know what the right bundle branch is used? Is that outside? Or y'all left? Either one. You could say both, probably, right? All right. Right ventricle, continue. So, as it exits, what is the valve that it goes into? The viper from the right ventricle up into the what? The pulmonic valve, the pulmonary valve. All right. Pulmonic valve and aortic valves collectively together known as semilunar valves. All right. But the one that exits the right ventricle into the pulmonary trunk is the pulmonic or pulmonary valve. Now, the pulmonic trunk is it's a large vessel before it splits into the pulmonary arteries, right? And the pulmonary arteries, we already know, are unique because they're the only arteries that carry the oxygenated blood. Okay, very good. So looking at this, I wanted to do, as we're exiting the pulmonary valve, into this large structure here, essentially is the pulmonary trunk, and then we go out into the lungs, all right, through the pulmonary arteries. Left atrium, again, thickness is not so important because it's not a really muscular contraction that necessitates the movement of blood from that. Forms most of the base of the heart. We learned that yesterday as far as heart surfaces are concerned. And pulmonary veins, which inverse of the pulmonary arteries are the only veins that carry oxygenated blood, right? Just about which direction the blood is flowing. Smooth wall, but there are pectinate muscles in the auricle or the appendage, again, same. And then through the mitral valve, which again is the only one that has 2 valves. Does anybody know why it's called a mitral valve? because that hat right there is called a bishop, it's called a mitre, bishop's mitre. So you see that it has just two pieces to it. Bicuspid valve is the technical term, the mitral valve is what you'll see it here referred to clinically. I don't think I've ever heard it referred to as the bicuspid valve in clinical practice. All right, so you hear it called the mitral valve. But that's why it's called the mitral valve. And here, again, the foraminal valve, which is what passes between the atria and fetal circulation, should be the fossa ovalis in a postnatal heart. Okay. And looking at this picture, even though it's a cartoony illustration, you can see the smoothness of the atrial wall itself versus the pectinate muscle here within the auricle. We'll see the rougher surface within the auricle. Okay. Questions so far? Pretty straightforward so far, I hope. Yeah. All right. So this is what I was talking about, right? Thickest, about double what the right ventricle is, and again for the same reason, just because it's got to push against that systemic circulation. And you know, caveating off into a little bit more pathophysiology, besides hypertrophic cardiomyopathy, what do you think happens to the heart with an increase in systemic blood pressure when somebody has hypertension? Well, imagine like when you go to the gym, right, and you lift progressively heavier weights, what happens? Your muscles hypertrophy, correct? Right? If the heart has to press its musculature against a progressively higher and higher pressure or weight, what do you think happens to the heart musculature? It remodels. Hypertrophy, exactly the same thing, a pathological process. So even though it's not hypertrophic cardiomyopathy, which is its own unique disease process in pathophysiology, when it's pressing constantly against a higher pressure, it remodels. So it grows, and what happens is it grows inward, right? Meaning the same thing. It has less blood to eject with every stroke, right? With every pump. So what does that mean? Less blood is ejected, less blood is getting out to systemic circulation. So what happens there, you think? What does that cause? If not enough blood is being pumped out per beat, what do you think it has to do? Beat more against higher circulation, higher pressure, higher systemic pressure, which then causes further remodeling. And so that is sort of the downward pathophysiology of why hypertension eventually leads to serious heart disease. If that makes sense, right? So I want to draw attention to this as well. Two papillary muscles, just remind me when we get to the picture, because it does look like there's three of them, but one is just a singular muscle with two peaks, two heads on it, all right? So I don't want you to get confused if you're to see a picture like that or anything. So let me just remind me to point that out if I forget. But it's just two because, again, it's a bicuspid valve. Only two leaflets on the mitral valve, so only two things need to hold it closed. All right? And then out into systemic circulation through the aortic valve. Okay? So we have blood in through the vena cava and the coronary sinus, down into the ventricle through the tricuspid valve, up into the pulmonary trunk through the pulmonary valve, back in to the atrium, left atrium through the pulmonary veins, down into the left ventricle through the mitral valve, and then up and out through the aortic valve. Okay? You can remember that, easy. All right? You can draw, just remember that. The rest of this stuff is sort of ancillary. All right? It's just that will help you, understand not just the stuff in this class, but conceptually it seems easy, right? But if it help you also when you get to pathology classes, when you have to think about pathologic function of the valves, right? If you know when blood is supposed to be running over the valve, and you know when blood is not supposed to be running over that valve, you can determine if it's a regurgitant murmur, meaning blood is flowing backwards, or if it's a stenotic murmur, meaning that there is a narrowing of the blood, of the valve itself, all right? So just understanding that blood flow, as simple as it sounds, can help you walk your way through a lot of stuff when you get to actual cardiology class, all right? And we're going to reinforce this over and over again, but just understand, if you help yourself be able to walk that blood through the heart, you make a lot of money, all right? So, we're going to talk about this. We have a special part just about coronary circulation, but just as a prelude, there are cusps, there are the chordae tendineae and the papillary muscles that hold the valves closed, the atrioventricular valves closed. Right? There are none of those in the semilunar valves, which is the pulmonic or the aortic. What helps close them is a physiologic retrograde flow. They have like a very deep cusp, so the blood just kind of fills it up, and it's like a gasket effect. It closes it down. Why is that important now? Because coronary circulation in the bottom part of the aorta, just as it comes out of the aortic valve, are two openings called ostia, right? And we're gonna get to all this. I told you I see butterflies sometimes, and this is a preview, all right? So we're gonna get to all this. Well, they have two openings called ostia, and those ostia in ventricular diastole supply blood to the actual heart itself, the heart muscle. All right, so that's what that bottom bullet means in case it doesn't make any sense, but it will make more sense in a few minutes, okay? Any questions? All right. So, this is what I was referring to. You see how that looks like it could be defined as two muscles. That is a single papillary muscle, all right, because there are just the two leaflets on the bicuspid mitral valve. Clear enough? All right. Okay, the septum. The middle part. And this is why I started talking yesterday about those external landmarks, right? If you're trying to orient yourself to an anatomy picture or a specimen, and you don't really understand how you're looking at how it's oriented, and the heart is just there. If you can maneuver it to where you can, okay, that is the interventricular sulcus, right? We talked about that. Well, then you can identify left versus right, and you can take it from there. There are a lot of other ways too, but I just think that being able to look at something regardless of its orientation and to understand what you're looking at is important, especially because I said, you're not always going to be seeing the same pictures that you see on the slides and so on and so forth. So, interventricular septum, simple. It's just the middle thing that divides the line of muscle that divides the two ventricles, okay? It has the bundle branches, right? The right and left bundle branches as far as the conductive fibers, and then down farther than that of their Purkinje system, and we'll talk all about that tomorrow. All right? The fibrous skeleton, so it's not really a skeleton per se, obviously, it's more dense fibrous tissue that kind of separates the atria and the ventricles. Because again, we have to have an organized distribution of the electrical charge in order to have an organized contraction and an organized rhythm, right? So if we have the atria have to contract first, fill up the ventricles, and then the ventricles can contract. If there was no kind of electrical insulator between the two layers, right, what would happen? There would be no delay in the charge, and everything would just fire off at once. So it would be chaos. Does that make sense, everybody? Instead of being organized atria and ventricles, it would just distribute out to the entire thing. So we have not enough time for ventricular filling. We have a reduced ejection fraction, meaning not enough blood leaving the heart. We have a dysrhythmia. Does that make sense, everybody? Okay. If it doesn't, hold on one sec. But so this is what an insulator looks like. You like that? These are old headphones from Walkmans. This is a wire that used to connect headphones to music devices. All right, but see, check this thing out. The blue thing, right? Do you see? Let me call your attention to this right here. The atrioventricular bundle. Anybody know another name for that? The eponym for that? Bundle of His, I think I heard it. Bundle of His, right? It is the only electrical tract that is supposed to exist physiologically, anatomically, to allow a brief delay that goes through and that has an organized rhythm that would then discharge the electricity through the ventricles for a simultaneous contraction, okay? So if that wasn't there, what potentially could happen, and I'm just going to walk side to side here, if what potentially could happen if this blue part, which is the fibrous skeleton, wasn't there, it would just go all the way across. It would just distribute through. Because we talked a little bit about it, we're going to talk a lot more tomorrow. Remember, no interstitial space, no interstitial fluid between cardiac myocytes, right? And the reason for that is because the charge has to distribute quickly. milliseconds for a heartbeat, right? So if that wasn't there to protect that and sort of insulate the top from the bottom, we would just have a full discharge. Am I making my point? Is the horse dead now? You guys got it? All right, cool. But the other things that it does, as you can see, it encircles all of the valves. So it does provide some rigidity and support in that dense fibrous tissue to help maintain the patency of the valves themselves, help prevent the valve from stretching abnormally as well. So it has a lot of physiologic purpose. But in my opinion, this is just my opinion. I think the most important one is the insulation property. Okay. Okay. Any questions? All right. I'm going to talk briefly about fetal cardiac shunts, and I've already mentioned one of them, which is the foramen ovale. What does that mean in English? Oval hole is really what it means, okay? And that's exactly what it is. It's just an oval-shaped hole that goes between the two atria. Between the two atria in fetal circulation, right? And what it does essentially is it allows a bypass, a majority bypass of the right side of the heart. Because again, we don't really need, in a fetus that is attached to the placenta that has fluid-filled lungs that are not mature and do not really participate in oxygen exchange. Most of the blood is already oxygenated as it returns to the fetus, so it just needs to go out into circulation. So this is one of the shunts that allows that to happen, directly into the left atrium, down and out into circulation. Does that make sense, everybody? I have a picture coming up, the fetal circulation, that might tie it together a little bit better. But does that sort of conceptually make sense to you? And of course, that doesn't belong when you have now functional lungs. You're born, breathe, lungs expand, alveoli open. Now we can do oxygen exchange in our lungs. The foramen ovale closes within about 6 months to a year, typically after birth. If it doesn't, and I know this is on the slide, don't worry about it, it becomes what's called a patent foramen ovale. And then what can happen there? Does anybody want to guess what could happen there? Yeah.
Then the oxygenated blood that's supposed to go into the body is going to have deoxygenated blood.
It is. It's going to mix with deoxygenated blood, and that is a minor problem, but you're absolutely correct. But the major problem is what happens is we get blood pooling, especially, I know it's hard to see red on red, but you get sort of like an increase in blood that is delivered to the right atrium, to the left atrium. So some still does go down. Patient still it's a survivable thing, but it also sends some blood over to the left atrium, which means there's too much in there. So you can get an expansion of the left atrium, some blood pooling. With blood pooling, what happens with blood just being static? It coagulates. It likes to clump up. Here's a tip that's going to help you throughout the entirety of PA school. Static fluid anywhere in the body is bad. Fluid needs to be moving. Because what is static fluid? It's a swamp. And what happens in a swamp? Shit grows in it, right? And we don't want that, right? So static fluid is bad. You get blood pooling. What happens to a little bitty clot that breaks off in the left atrium? Where does it go? Left ventricle into the body. That's what we call thromboembolism, right? Okay. So sounds bad. Can be closed medically, surgically, I should say. And then this patient, if they were discovered to have a patent foramen ovale, they'd be on anticoagulation for the exact reason I just talked about. Okay? Ductus arteriosus. Let me see. I'm just going to show you, and then I'm going to go back. The ductus arteriosus sort of bypasses the pulmonary trunk and goes directly into the aorta, right? For the same reason. We don't need the oxygenated blood. We don't need blood going into the lungs. We need blood going into the circulation, okay? So let me go back. So it shunts blood away from the pulmonary circulation because we don't need it there. We have the oxygenated blood already from the mother's body. And so that is another little diversion pathway, okay? And when it closes, and this one should close within about 24 hours after birth, because it is a much more problem with deoxygenated blood than the other one. it closes and becomes a ligamentum arteriosum, so it's a remnant. And it's like an attachment, it actually helps sort of stabilize the aortic arch, but it's supposed to close. Let me ask some questions here. Does anybody know what this means for $1 million that I don't have? So it means decreased prostaglandins. The things that keep the foramen ovale and the ductus arteriosum open are prostaglandins, okay? Doesn't matter if you don't know what that is. Does anybody know something that blocks prostaglandins? NSAIDs, right? So in a preterm infant, when the body is not ready to close the ductus arteriosus yet, we give them indomethacin or Motrin. Ibuprofen helps close it, and then the baby can perfuse adequately, all right? So just a little gee whiz tip for you there. So this, I think, illustrates the sort of maternal fetal circulation a little bit better. You get umbilical vein, got all that good blood in it. Umbilical arteries, right? So we're getting our good oxygenated blood coming directly. We don't need it to go into the lungs, so it goes directly into the left atrium, down to the left ventricle, and up and out, okay? And the ligamentum, or the ductus arteriosus, same thing. Anything that does make its way into pulmonary circulation could just shoot up and out, back into systemic circulation, all right? So don't spend too much time memorizing this. Just talk about, don't memorize anything. Learn this shit. Learn the structures that we talked about, the foramen ovale and the ductus arteriosus, and what they do and why. But don't spend any time really memorizing maternal fetal circulation. Okay, is that fair? You guys understand?
I got a question.
Yes, sir.
Could you explain again what happens like within that 24-hour period of babies after birth? What happens to the ductus?
It closes. It closes.
What is it? Does it like gain a new role?
Yeah. Let me go back. It becomes the ligamentum arteriosum right here, which it actually becomes a bit of stability, right? So if you look in the picture in the next one, so this little outflow tract, which is the duct, closes and then just becomes this little green guy right here, and actually helps stabilize the aortic arch on the pulmonary trunk. Okay? Does that answer your question?
Yes, sir.
All right. Any other question? All right. Wonderful. Okay. Any questions about that? Now we're going to do the valves. It's going to be semi-redundant. I hopefully tie this together a little bit better. All right. So the AV valves, that one's easy. They go between the atria and the ventricles. Right? Semilunar valves, they're titled as such because apparently when they're closed, they look like half moons. Does that help? No, it doesn't help. The semilunar valves go between the ventricles and the great vessels. All right. What is the only one that has two cusps? The mitral valve or the bicuspid valve. Exactly. The rest of them have three. It's easier that way if you just remember that. All right. So I'm going to talk a little bit about this slide. So listen, because I got to reword it a little bit. It's accurate. There's nothing inaccurate about it, but it's the pressure change more so than it is the weight. I think it's more the volume of blood that really forces it open. So when you're talking about blood leaving the atria going into the ventricles, it is not forceful atrial contraction that moves that blood down, okay? In the initial part, when they're filling, so we have an atrial systole during a ventricular diastole. When the atrium is filling, eventually the pressure, the volume of blood that creates an increased pressure, the pressure in the atria exceeds the pressure in the relaxed ventricles. Does that make sense? And so that opens the atrioventricular valves. Then we get atrial contraction, all right? So most of it, I don't want to say passive filling because I think that's the wrong way to look at it, but it's not a forceful opening due to atrial contraction that shoves the blood through. It falls down because of an increased pressure, and then the remnant that would be in the auricle, or that would be the leftover in the atrium itself, is forced down through contraction. Does that make sense to everybody? Okay.
Is that just like a sense of like work smarter, not harder? And then I guess like
I suppose you could say it that way. Yeah. I
so
mean,
it's less contraction on the atrium then because most of it already falls from the weight. Am
I mean, maybe, but you can think about it that way, but truthfully, the myocardium is so rich with mitochondria more so than even skeletal muscle. I mean, it's meant to beat all the time. I guess it does contribute to efficiency and have that removed. In a certain manner, it does contribute to efficiency. So you can think about it that way. If that helps, sure. But I'm not sure if I would be lying if I said if I knew that is the anatomic purpose or physiologic purpose for it, but it makes sense. It makes sense, yeah. And so that really caveats into the second one, which is contraction versus relaxation of chambers, right? So atrium are at higher pressure than the ventricles. The ventricles in diastole, they fill up. Now we're switch over to ventricular systole, okay? So what happens? The ventricles squeeze. Pressure goes up in the ventricles. It's much higher than it is in the atrium. So blood sort of moves up towards the atrioventricular valves because they're closer, and then bounces off the valve and then out through the semilunar valve when pressure is sufficient to pop it open. Does that make sense? And what's helping us hold that atrioventricular valve closed on both sides? Capillary muscles in the chordae tendineae, right? We talked about it yesterday. Now the ventricles are squeezing. The papillary muscles are just muscles, just myocardium. The whole thing is contracting. That means it's pulling on those chordae tendineae, making sure that that parachute stays closed and doesn't prolapse up into the atrium. Does that make sense? Yeah? Maybe? Okay. All right. You got to chew on it a little bit. We're going to talk about it some more. All right? But again, that's what this says. As we get higher pressure in the ventricles, it's going to tend to go bump up against the mitral valve. Let's just say, let's talk about the left ventricle because it's conceptually, I think, the easiest one. Bump up against your mitral valve, closes the mitral valve. Papillary muscles help keep it closed. Goes up into the aortic valve. Once the pressure is sufficient, blood goes out. Yes, sir?
So do the semilunar valves operate the same way as the atrioventricular, where it opens the valve based off pressure, and then the heart pumps due to muscular action?
More or less. But the main difference is that they don't have papillary muscles to close them because they're the outdoor. And so what closes them, and I'm going to get to that, is they have a deeper cusp, so it's more like a gasket that keeps them closed. Right? And the other thing is they also don't have papillary muscles because ventricular filling, when the ventricles are in diastole, atrial pressure sending that blood down is not sufficient to regurgitate or prolapse those semilunar valves. Does that make sense? Is that your question?
Yes.
Okay. Does that make sense, everybody? Okay. So like we need that extra support. We need that extra buttress on the valves that go from the atria to the ventricles because ventricular contraction is so forceful. Ventricular filling from the atria is a much more passive, low pressure system. So blood's not going to rush up and then bump into, say, the pulmonic valve and open it on accident. Does that make sense? Okay. So that's why we don't have those papillary muscles there or anything like that. It's just more of a gasket effect that keeps those closed. So as we're going out, just this little ventricular systole on this side, right? It doesn't have the papillary muscles in it or anything, but blood's going to kind of go this way because it's closer. It's going to bounce off that valve and it's going to go up and out once it has enough pressure to pop open the pulmonic valve. And then the same thing on the other side. Does that make sense? All right. What this is just saying is that this is a pathology slide essentially. So if you have abnormally slack or lengthy chordae tendineae, which is a problem in Ehlers-Danlos or other connective tissue disorders, they can be excessively stretchy. So as the left ventricle squeezes, it can actually push the valve back up into the atria slightly. That's called mitral valve prolapse. If you have myocardial infarction, creates a dead tissue, necrotic tissue in the area where a papillary muscle is. The chordae tendineae can actually break off. All right. So if you have, atherosclerosis, it can affect the you can get sclerosis primarily of the aortic valve, so aortic valve stenosis, meaning it takes a lot more pressure to pop those valves open, right? And all of these things create murmurs, which you'll learn about later. But anyway, there's a lot of different pathologies. That what we just walked through, normal blood flow up, down, and then up and out. If it goes awry because of a pathologic valve, then blood isn't flowing the way it's supposed to flow. That creates turbulent blood flow. That creates a murmur, and that can create a problem. So that suffices to say for this slide. Does that make sense for everybody? And here's a good example, right? So ruptured cord. So where these muscles are, or is it the inferior towards the apex, right? It's a common site for myocardial infarction. If it happens to hit where the papillary muscles are, they pop, they die, and then you have a defective valve, which is a two-way door. That's not supposed to be that way. Mitral valve prolapse, I don't know if you can really appreciate this, it's just a drawing, but these are like excessively stretchy. And so they, instead of holding down where they're supposed to, it allows blood to prolapse in, okay? So it's like a circuitous route to get out of the ventricle, okay? Ventricular systole versus diastole, we're gonna go through the cardiac cycle tomorrow, or the next day, I can't remember. But typically we talk about systole, diastole, we're talking about the ventricles. There's also atrial systole and atrial diastole, of course, because all four chambers have to fill and eject their blood, so. But ventricular systole, right? It says the same thing we just said. AV valves close, because in ventricular systole, when the ventricles are squeezing, they're supposed to be sending blood out of the heart, not back into the atria. So the atrioventricular valve closed, semilunar valve open. And then in ventricular diastole, the opposite. Because what's happening in ventricular diastole? We're filling up the ventricles, right? Does this slide make sense to y'all? Yeah? All right. And then this relaxation right here, again, is what creates a lower pressure in the ventricles, higher pressure in the atria, which is what opens those AV valves. Okay? And then, I think we have already gone over this, so it's a little bit, again, repetition is the key to adult learning. But as the ventricles relax, the papillary muscles are relaxed because all of the muscles, it's all the same, it's just muscle. So with that relaxation, it allows the valves to open. Because at that point in ventricular diastole, when the muscle in the ventricles is relaxed, that's when they're supposed to be filling up with blood, right? So those cords are slack. So the reason for the highlight of the slide is I think there's a misconception sometimes that the papillary muscles contract in order to pull the valve open. That's not what they do, okay? They help keep it closed. So the ventricles are relaxed, the papillary muscles are relaxed, the cords that attach to the valves are slack. Ventricle fires, contracts, papillary muscles contract, pulls slack onto the chordae tendineae, keeps the valves closed. That's essentially what this slide says. Does that concept make sense to everybody? Okay. If it doesn't at first, I told you, like first pass is difficult, right? It's easy for me to say, does that make sense? And everybody's like, yeah, it makes sense. And then you go back and look at it. No, it doesn't make any fucking sense. So if it doesn't, just try it, keep trying to work. And if it doesn't make sense at all, we'll go over it again. All right? We'll go over it again. As many times we have. But if you look at this, what phase is this in? What phase is this heart in? Ventricular diastole, right? And why? Because the AV valves are open. The AV valves are open, meaning what? The papillary muscles are relaxed and the chordae tendineae are slack, right? If the picture was reversed and these two guys were open, it would be completely just the opposite, exactly the opposite, right? We'd be in ventricular systole, papillary muscles would be contracted, the chordae tendineae would be tight, right? And I think on your slide it says bicuspid valve, but I put mitral valve because again, clinically you're going to see it's the same thing. It doesn't. You can make the change. It's just Mitral valve is what you're gonna refer to it as clinically. I mean, you're not gonna work in an anatomy lab, you're gonna work in the clinic, so mitral valve is what you're gonna hear it called. But this is just a picture of the concept. In ventricular diastole, and then in ventricular systole, and specifically left ventricular. Okay? Semilunar valves, okay, we got it. Aortic and pulmonic, we know which way they go. We know where they're coming out, right ventricle, pulmonic, left ventricle, aortic. And then this right here, I think it says a similar thing about the atrioventricular valves, I didn't highlight it, but the valves open in the direction of blood flow. It's an outdoor, right? So when the valves open in the atrioventricular valves, they project into the ventricles, right? Does that make sense? Because blood is flowing through them, so it's an open door. And then when they close, right? The atrioventricular valves, which way is blood going out of the heart, so their cusp project out into the vessels. Simple enough? That's what that top bullet means, all right? And then, this is what I've been talking about with the gasket effect of the cusp, and I have an actual anatomical picture, I think it'll highlight it pretty well. But, again, there's no chordae tendineae, there's papillary muscles to keep these things closed, it's just the weight of blood falling into these cusps that creates like a gasket-like effect to keep it sealed, okay? So now we're looking at a picture of ventricular systole, right? Right, so ventricular systole, the semilunar valves are open, right? So what is going on with the papillary muscles and the chordae tendineae in the ventricles? They're contracted and they're tight, right? And why? To keep this closed and this closed. Securely, not bumping up into the atrium, all right? The coronary blood flow, okay? Most coronary blood flow, meaning blood supplied to the actual myocardium, happens in diastole. As that blood sort of is ejected out into the aorta, some of it falls back down into those cusps, and then what you see here are those coronary ostia. What is an ostia? An opening, a window, right? So that's it. As blood comes down in ventricular diastole, blood flows into the coronary circulation, right? And that's when the heart feeds itself. We're going to go over that a lot in the next few slides, and probably after break, we'll see. But do you see, let's see, this is a decent illustration, how, sort of the depth. I know it's just a cartoon again, but you see sort of the depth of these cups, right? So as that blood flows in, the walls all sort of just smash together, creates that gasket, so the blood stays closed, so blood doesn't pathologically flow back through it, all right? If it doesn't work, then you get what's called regurgitation, like pulmonic or aortic regurgitation, flowing back through, right? This is a little bit as the sort of, these flap down and close, it kind of opens this ostia and allows us to get blood into the coronary artery. All right. And here's that picture I keep referring to. Here it is finally. You see how deep that is, right? And it just, again, it does create this sort of gasket-like effect to keep that closed so there's no regurgitant blood. Okay. I gotta send my 5 bullets. This is one, by the way. Yes. All right, no heart valves. There's no valve in the vena cava. Coronary sinus, right atrium. So there's no valves there. There's no valves in the pulmonary atrium or the pulmonary veins. All right. So if there were, I would have told you about them. So there you go. These generally, the point of the slide actually is that as the ventricle does contract, it sort of mechanically closes or just kind of smushes close the opening to those to prevent regurgitant flow back into the venous system. All right. But again, a much lower pressure system returning, so a lower level of necessity for a physiologic mechanism other than just the pressure closes the door, okay? All right, I can feel that you guys need a break. Does anybody have any questions? All right, if you do, stand by. If not, enjoy your break. See you back at 11.
So, do I spend too much on which is crazy how it's still what process is it? What usually actually I can't remember that shit. They have a weird was I bought my wife, she didn't try it yet, but I just like strong coffee. Like the only thing I wish is like if the depends if I was a dark zero on a medium, like you can dark roast. I don't know. It's like 80 grand. 80 grand. good. I think like more serious, but then it's better than that. It doesn't like listen. I wonder how often you do it. I enjoy the practice. When I use it like that. Dude, I saw she did this on YouTube. Yeah, I'm eager for that.
It's funny, as I got there right at 7:30,
Yeah, when's it come to junction of the beat it, then you're 60-40, So we're not looking at the back. That's why you're saying, you said that's just like one sort of wash stuff. But it also captures the cuts, like as it cuts down. So those are, and then, but that's basically the quarantine and no, no, so right, yeah. So this device. That's control. Yeah, I mean, that's really like that is the pressure option. It's a signal, right? So yeah. As they project out, yeah. I mean, this is basically, it's not connected by the yeah. So basically what he was saying is like,
this was the right age.
yeah. And then I say, yeah, so he was saying, it was muscle. Basically, you can do not only normal surgery. So that's our basic. If this, what I was saying, if they're not open, like they come back down, open, when pressure get out, and the heart would open. We're gonna talk about, yeah, that's, it's supposed to have the one covered by that insulation so that it travels. So that'd be part of it, that'd be, so the diastolic is, that's what I'm talking about, because the contraction is happening, it's pushing out into the muscles in the body. These two are just luminal valves.
Alright. Hearing some good discussion. Everybody have any questions? Any questions? No, I'm not putting you on the spot, but I mean, somebody might have the same question, so what do you got?
Oh, no, I have a question. I didn't think what we're gonna
Think you're better than me? I'm just kidding.
Depends what your team.
Huh?
Depends what your team.
Which team?
Yeah.
For what sport?
Football.
Which football? College, NFL?
Football.
We're Cornhuskers. Has nothing to do with your medical center.
We are.
And then, Saints, honestly.
Okay, I respect that.
So both like, for a while. But what about you?
I mean, there's a giant Dolphins fan on my table, so.
Dolphins?
Yeah.
You guys just got Quinn Ewers, didn't you?
Yeah. You know, Tua's got too many concussions, so it's a good backup.
How about this side? You guys watch football? Huh?
Cowboys.
All right, any questions though? Does anybody have any questions about this stuff? I forgot what we're talking about. No, okay, so I had a good question, and let me clear, because he asked a good question, and I wanna bring it up. So, when the atrioventricular valves are open, right, those cusps are projecting down into the ventricles. So as blood rushes towards them in ventricular contraction, it does catch those cusps and help force those closed. So it's very similar to the other side, where blood is falling down into the semilunar valves, but it's just the opposite. Does that make sense to everybody? So blood catches them, closes them, papillary muscles are tight, chordae tendineae are tight, keeps them from going too far with the force of the blood rushing past them. Does that make sense to everybody? Okay. Yes.
So the contraction is so then they don't prolapse, right?
The contraction of the papillary muscles and the tautness of the chordae tendineae is so they don't prolapse. Yes. So they close sufficiently, but not too much, right? Because that force, again, the reason why those papillary muscles are there is because the force of ventricular contraction is so strong, it would force blood up and into the atria, pushing the valves up. So yes, okay? That make sense? All right, good. So coronary circulation, again, takes place during diastole. All right. Top bullet, hopefully self-explanatory. If not, let me explanatory it. It is, blood has to have its own circulation. Like blood, you would think, could theoretically diffuse nutrients and oxygen to the walls of the myocardium as it sits in the ventricles. It doesn't have sufficient time to do so to create sufficient nutrient and oxygen exchange. So it has to have its own unique circulation, which it does, of course, right? And we're not going to go too far deep. I'm going to tell you which vessels to really pay attention to, because there are anomalous vessels, branches off the left anterior descending that are in various formations. So I'm going to tell you which ones to pay attention to as we go through the pictures. All right. And we're not going to worry too much, definitely, about when we get down into the myocardial capillaries and arterioles and stuff like that. We're going to stick with the main veins, the main vessels, the main arteries. All right. So coronary arteries fill the ostia during diastole as that blood sort of retrogrades down from the ascending aorta and goes in there as the ventricles are relaxed, all right? And I'm not going to play this video because it's just going to say the exact same thing that I'm going to say, and it's only going to take up time, so you can watch it if you like. Most of the videos that we have in here, I have in here, are for another perspective, if you will, okay? And also, on that note, did anybody look at the, if you're looking at the main, like the block 1 cardiac page on Canvas, it has a University of Minnesota link to, that is an excellent link if you need like another perspective to look at something, because it has endoscopic videos, it has anatomic specimens, it has 3D heart modeling, and it has some explanation. So if like it's just not clicking and it's not making sense, sometimes it's a very easy way to go and just get a quick synopsis of something. All right, so anyway, that's for that. So coronary arteries, those two ostia that come off of the aorta are the main branches, the left and the right are coronary arteries, okay? The left turns into the left anterior descending. What does it sound like? It's on the front part of the heart going down, all right, exactly. Circumflex, what does it sound like it does? Goes around, and it exactly does, all right? Right main, and then there's the right marginal. It just says marginal, but in most diagrams, you're going to see it as the right marginal artery, not just the marginal artery, because there is a left as well. So just maybe make that note so you don't confuse yourselves. And then the posterior descending. Okay, what does it sound like it is? On the back, going down. Exactly, right? So we can sort of figure out where they are by the nomenclature, and then if you can remember which one's on the left, which one's on the right, it makes it a little bit easier. So these pictures are good because they are transparent, so you can see the circulation as it flips around the backside of the heart without having to flip over between an anterior and posterior view. You can just sort of see where the vessels supply what, all right? So looking at this one, excuse me, the left coronary artery, we're talking about the left side now. So I want you to pay attention to the left main, excuse me, left main, then the left anterior descending, right? on the front, going down, and the left circumflex circling around the heart, right? And what does it look like? You do need to know what areas they supply, all right? And that also becomes extremely useful. Like this bit of knowledge right here helps extremely when you start to diagnose weird energy on EKGs and what area of the heart is most likely involved in an acute myocardial infarction or an old one, right? Because the energy is weird traveling through necrotic tissue. So if you understand where the blockage probably is based on what you see on an EKG, this is where the foundation of that starts, all right? So, let me go back or forward. Left main, most of the anterior left atria. I'm going to flip back. We're going to just, hopefully the back and forth doesn't bother you too much, but does it make sense? This is, let me go to a different color pen because the red is really not working for us. Pen and color, blue. All right, so this is the borderline of the left atria, and you see the left main coming right across, feeding most of that left atria. Does that make sense? It's coming on the top, it's on the top of the heart where the ascending aorta is. What's right there next to it is the left atria. Easy enough for now, at least. Now you're gonna have to dig into this, right? Then you have the left anterior descending. Now we're talking about this one. Again, the one in front that just drops down. Excuse me. So, what is that in? Do you remember from yesterday I told you if you see that main artery going down, what groove is that in? The interventricular sulcus, right? So what do you think it feeds? The ventricles, but specifically what's that middle part? The septum, the interventricular septum. Yep, all right, so it feeds most of the septum there, okay? It feeds we haven't got here yet, but it'll make more sense tomorrow when we talk about electricity. It feeds the bundle branches, because the bundle branches are where the septum is. And for anybody who doesn't know what the bundle branches are, SA node starts the electricity, then it goes down to the AV node, goes down through the bundle of His, and then two different, within the septum, a left and a right branch of conductive fibers, and then at the bottom, it goes up into these things called Purkinje fibers. So it's where the electricity travels. That's good enough for now. But it is held within the septum. So the bundle of His and the bundle branches are supplied by the left anterior descending. What else does it look like it supplies mostly of? Just where it is? Huh? Left ventricle? Yep, left ventricle. Excuse me. And then, if you see this little guy right here, so this is, I'm going to come on the other side too. I wish I had a laser pointer. It comes around and it hooks and it goes right behind the heart. So what does it look like it supplies a little bit of too? The right ventricle. Just a little bit of the right ventricle, right? As it dives down and comes behind and kind of heads to the right there, all right? So we got the atrium, the septum, most of this ventricle, the septum and all its contents, right, which is the conductive fibers, and then a little bit of that right ventricle, right? Does that make sense? Like just visually, conceptually, does that make sense to you? Okay. Now the circumflex, let me erase all this ink. Now the circumflex is the one that circles around, okay? And it dives down behind here, right? So, it supplies the upper part of the left ventricle, where it is, right? It supplies, circumflex, it goes back around, so it supplies the back side of the left ventricle, all right? Some of the atrium as well, because it's right there. And then, I'm gonna go to this next slide. I don't know if you guys remember this. Just, don't worry about this one. Like, if I can cross something off the list, it makes me happy too. It's an anomalous placement of the SA node. Most of the time the SA node is in the right side of the heart, the right atrium. If it's anonymously, you know what I mean. If it's in the wrong spot, how about that? Then the minority of people, they may have problems if they have a left circumflex MI or a blockage. But don't worry about it, okay? So I added that back in, this slide's not in yours, I just put it back in so we could recover. Just looking at the slide on the left side, you're gonna have to obviously go over this more and more and more, but it just kind of makes sense if you just had to think about what it's apply, you could probably spit out most of them just looking at the picture. Left ventricle, left atrium, septum because it's in the interventricular sulcus, right? Maybe you wouldn't be able to get a little bit of the right ventricle because it doesn't make any sense. And you guys don't know what the bumper branches are yet because we haven't talked about it. But you can understand generally this stuff make kind of straightforward? Yeah? No? Alright. Let's start with the right. Alright. So again, like I said, think about this one not just as the marginal branch, but as the right the right marginal artery, okay, the RMA. Because that's usually what you'll see. And then the posterior descending. So you can see posterior interventricular, right? Everything has to have two names. But if you know it as the posterior interventricular, then you know what it supplies, right? So the backside of the septum. Okay. Good. So the RCA, which is the main, comes out here. Comes around to be the posterior descending. So this is the posterior descending down here on the backside, right? Posterior descending. And then the right marginal artery is just this main branch. And like I said, don't worry about all of these other diagonal branches. The configuration of those can be myriad depending on the patient's anatomy. So just focus on the ones that are in the boxes, the main ones that I'm discussing, okay? Make sense? Alright. So if you look at this, the right coronary artery, right atrium, based on where it is, right ventricle, right? Posterior septum, because the posterior descending is in the interventricular septum in the back, right? And then what did I say? I know that we haven't learned it yet, but what did I say is the electrical stuff that's on this side? The SA node and the AV node, all right? And again, we haven't talked about that. We will talk about it tomorrow, but that's on the right side, all right? And so because those arteries supply that musculature, they supply that as well. And then here's, again, just because this little guy, this little bit, depending on how far it goes, may supply a little bit of the left ventricle. But again, if you want to make this easy on yourself, the right side supplies the right side stuff. The left side supplies the left side stuff. When we layer on where the conductive tissue is tomorrow, it should make a lot more sense. Does that, I mean, just basically, does this make sense to you? What's supplied by what artery? There's really no curveballs other than the conductive tissue.
I have a question.
Yes, sir.
Just to make sure I'm seeing this picture right,
Uh-huh.
the left anterior descending
Uh-huh. Yeah.
is that intersecting with the left circumflex artery?
The left anterior descending, no. So the left anterior descending, this is the left main, right?
Mhm.
The left anterior descending is this guy right here, going all the way down to this. So this big one is the left anterior descending artery, right? I'm gonna go on the middle so everybody can see what I'm talking about. So if you see, where the hell is my one? There you go. So the left anterior descending comes off the left main here and goes down that right there. The circumflex is this one. I'm gonna erase that slide, erase that. The circumflex is the one that comes off the left main, hooks down this way, and then goes around back. So what you're seeing here, it's sort of like the lighter color, is the posterior surface of the heart. Okay? Does that make sense, everybody? You need me to show you on this side? Like, I'm gonna anyway. So yeah, so this lighter color that you can see here, sort of like this, like more purpley hue, that's the posterior surface of the heart. So the circumflex goes around back. Okay. All right. Any other questions? Okay. Let's see. And, there is redundant circulation, and the point what we're trying to make here is, does anybody know what an anastomosis is? Anastomosis is basically where two vessels sort of come together. There can be pathologic anastomosis, and then there can be beneficial, if you will, physiologic anastomosis. So the fact that most of the heart is supplied by more than one area is a physiological advantage, because if there's a blockage on one, there's a collateral circulation that can still feed it, right? What happens if there's a blockage, like a long-term blockage or a necrotic area, is that there's neovascularization that forms like new vessels that go around that blockage and form anastomosis with the existing vasculature, right? Why is that important? It's important because if a clot is building, the heart can neovascularize. What does that mean? New vascularization, create new vessels to go around it. Theoretically, but most of the time, it works. Most of the time, anastomosis are circuitous pathways that are anomalous, meaning they don't belong there because of some sort of pathology. All right. Coronary veins, right? We have there's a lot of, everybody knows cardiovascular disease, right? Coronary artery disease, CAD, you've heard that before? Or atherosclerotic vascular disease. So atherosclerotic vascular disease is the overarching term. Just means you have plaque, fat buildup in your vessel. Coronary artery disease is a subset of that, meaning plaque buildup in the coronary arteries themselves. And what does plaque buildup, fat buildup in the coronary arteries lead to? Heart attacks. Heart attacks. That's why it's a problem. There's other reasons, but that's mainly, right? Coronary veins really don't cause a lot of clinically significant pathology, all right? So we don't pay a lot of attention to them, but this is anatomy, so you have to know where they are and what they do, okay? So main point here, coronary sinus, remember the atrioventricular septum? Right, that big thing that goes around, kind of separates the atria from the ventricles. That's where the coronary sinus is. The sinus is just like a large pool area, like where several vessels come together, so a large area of blood flow. So it's not called a vein, even though it is a vein. It's called the coronary sinus because it drains several areas. Okay. Tributaries from the coronary sinus that drain into it are the great cardiac vein, which sort of tracks. And so here's the thing. You don't have to memorize what the veins drain and what the arteries supply, because they generally are in the same area. So if you understand what the arteries supply, you'll understand what the veins are draining off in the same area. Does that make sense? And the reason I say this is because you don't have to study two lists. You really just have to make one. Does that makes it a little bit easier? Right? So the great cardiac vein is by the anterior interventricular artery. So what does it drain? Most of the left ventricle and the sinus, right? Right. We got the middle cardiac vein on this one. The anterior cardiac veins right here. Where's the middle cardiac vein? Small cardiac. There it is. Middle cardiac vein along the posterior, right where the posterior interventricular or posterior descending artery, right? So again, the point is, don't make yourself two long lists to figure out what's being fed, what's being drained. Make yourself one, because they're in similar locations, and anatomically so, because that's where the capillary exchange is happening within the myocardium. That's where this stuff has to escape from. That's where the waste products in the deoxygenated blood have to escape from. All right. The other salient point onto this is that anterior cardiac veins don't drain into the coronary sinus, they go directly into the right atrium. So there's yet another thing that drains directly into the right atrium. So we have the superior inferior vena cava, we have the coronary sinus itself, and then we have the anterior cardiac veins all dumping deoxygenated blood into the right atrium. That's really all there is to say about that. So, and that's why anterior cardiac veins are highlighted here, because they just flow directly into the right atrium, right? Without going into the coronary sinus. We're almost done, you guys. I can feel it. We're almost done. Alright, so, real quickly, ischemia versus infarction, right? Ischemia leads to infarction, prolonged ischemia leads to infarction. And what is ischemia? It's a reduction in oxygenation, a reduction in blood flow, if you will, right? Really, it's a reduction in blood flow, but what really is the problem is a reduction in oxygenation of that tissue. If the flowers aren't fed for a long enough period of time, what happens? They die. That's infarction, okay? That's what we're trying to prevent in an acute myocardial infarction, even though it's called that. We're trying to prevent necrotic tissue. We're trying to reperfuse that area of the heart before we have real infarction and necrosis, okay? Risk factors, you guys know the risk factors for heart attack? Smoking, diabetes, told it. Obesity, lack of exercise, sedentary lifestyle, bad diet, family history, age, alcoholism, so on and so forth, okay?
Why is type A personality on there?
Because you're under stress, man. So much stress. iPad is what it's on. Here, I don't know, everybody's probably too young to remember Sanford and Son. I'm coming, Elizabeth. Right. So, you know, it's cardiac, cafe, coronary, they call it stand up. Oh my God. Never mind, shut up. So, this is what we're trying to do. We're trying to reperfuse this before it becomes, or excuse me, we're trying to reperfuse this before it becomes acute, right? Subacute, days old, even though it looks kind of ugly. What the hell? Sorry, I was right the first time. Let me stop to erase all of this. What we're trying to do is, see how this is like transmural, meaning it goes to the entire wall? Right, this is just, does that look good, that white tissue? Also the fact that this isn't in a person, so it suggests that this is a bad outcome, right? So, that white tissue, that's dead necrotic tissue, that's days of infarction. That's days of ischemia, that is infarction, that is dead tissue because it hasn't been perfused. Acute, right, when we have it ongoing right now, this is when we see these electrical changes, the patient is feeling pain, we can still reperfuse that myocardium and save it before it becomes that ugly white mess. All right? So, and then this is healed. So eventually the subacute will look at that healed area, but again, you can tell that area of the myocardium is dead and damaged, so this patient is going to have some kind of pathophysiology, some kind of dysrhythmia chronically, probably some sort of valvular disorder. All right, so that's essentially what we're trying to prevent. Ultimately, if you have a real transmural event like this, and does everybody notice when I say transmural, all the way through the wall, it can actually open, break, right? So that's bad. Yes, were you have your hand up?
Is it just me, or was there some kind of neovascularization in that healed section?
In the healed section, almost certainly there is, yeah. I mean, if you're talking about some of the, it's the myocardial, you're talking about something like this right here. I mean, typically it does, or it's got to perfuse around that. So whatever branch died in that space right there in the left ventricle, it did almost certainly create some neovascularization around it, or else the patient wouldn't have made it, essentially. So yeah, something happened to reperfuse the areas around it. Otherwise, it would have just spread and continued. So yeah. Any questions? Yes?
So is that healed area almost like serving as scar tissue?
More or less.
Yeah.
Yeah, not really non-functional, non-conductive more so than anything. That's the real problem. I mean, the integrity of the heart wall, of course, is a big problem, right? It can burst. But the lack of electrical flow through that section, because that's just dead tissue, so it's not contractile anymore, it's not conductive anymore. So we have, again, we're going to have a dysrhythmia, we're going to have a reduced heart, probably a reduced ejection fraction, we're going to have a higher risk of subsequent myocardial infarction, and we're going to have that neovascularization that may or may not be, sufficiently perfusing the tissue surrounding it. So yeah, it is basically scar tissue to answer your question. Yeah. All right. And then this is a neat little picture of coronary vessels. We're almost done, like I said. This last part is pretty easy. It's a couple slides. Alright, so, as we're going out of the heart, remember, first day I'm like, aortic arch front to back, alright? But let's conceptualize it as right to left, okay? So coming out of the left, so ascending from the left ventricle, first pulls out of, first vessels that branch technically are the coronary arteries, right? Then we go up the aortic arch, and the first one is going to be the brachiocephalic trunk, or you might see it called the brachiocephalic artery, or if you're in surgery, you're almost going to hear it certainly called the innominate artery, all right? I will refer to it as brachiocephalic in here just so you know. But if I say trunk, artery, they're the same, okay? Yes?
You said this is going from right to left.
Yeah, so if you're looking, right coronary, we're hooking up and we're going this way, okay? So I'm looking at it like this, all right? Even though it doesn't go that way, just conceptualize it that way. You know why? Because it makes it easier to remember the branches, because you have the brachiocephalic, which becomes then the right subclavian and the right common carotid, and the left is the left common carotid and the left subclavian, okay? So the way I remember it, if you're thinking in a right to left fashion, it's alphabetical. Brachiocephalic, common carotid, subclavian. All right, does that make sense? Just an easy way. It's not a trick. It's just a stupid way to remember shit. Like that's the only way I can remember things. All right.
Old college football playoff, BCS.
There you go. BCS. Yeah, I'll take that. But go back. So, and then the ascending at the arch, right? So these are technically, so this is a fine point, but it's important. Those are not branches off of the ascending aorta. They are branches off of the aortic arch, okay? The only thing that branches off the ascending aorta are coronary arteries, right? Coronary arteries, because they branch as soon as the aorta arises out, okay? So that's a fine point, but it's an important one, all right? And then the descending obviously goes down until it splits into the iliacs and so on and so forth, right? Just a point of maybe interest, or just so you know, the diaphragm has several hiatuses that go through it. A hiatus is basically just a passageway through. So the descending aorta passes through the aortic hiatus. Anybody ever heard of a hiatal hernia? Right, so that's where part of your stomach comes up through the esophageal hiatus. And we'll talk about that in the GI section. But anyway, in case anybody was wondering how does it get through the diaphragm, that's how, through an anatomic hiatus. And again, brachiocephalic, which then does give rise to the right subclavian and right common carotid. And then the main branches being the left common carotid and the left subclavian, right? And this is what I'm talking about. Seems like a stupidly fine point, but it is still. They branch off the arch, not the ascending aorta. Here you can see inside you, so you see brachiocephalic trunk, right common carotid, right subclavian, left common carotid, and left subclavian. So right to left, okay? Vena cava should be pretty simple. They both enter into the right atrium. Inferiors on the bottom, superiors on the top. All right. The inferior vena cava comes up and returns into the right atrium through the cable hiatus, again through the diaphragm. All right. And then we have the pulmonary trunk, which I already discussed. Right. The pulmonary trunk is that first part after the pulmonic valve, where it hasn't split into two vessels yet. That's the pulmonic trunk, or the pulmonary trunk. Then it splits into the pulmonary arteries that go to the lungs. All right? And then the pulmonary veins, this is the main difference between them, other than the type of blood they carry, is that there's 2 pulmonary arteries and there's 4 pulmonary veins. Okay? 1 on each side. Or 1 on each side of the pulmonary trunk, 2 on each side for the pulmonary veins. And you can see that here. pulmonary artery going out to the lungs, 1, 2. Pulmonary veins coming back, 1, 2, 3, and 4. Okay? And where are the pulmonary veins dumping into? Huh? The left atrium, yeah. They are carrying our freshly oxygenated blood from the left atrium to dump into the left ventricle and then to be sent out into systemic circulation. I added this one only to highlight again the pulmonary trunk, right, as it comes out the pulmonary valve, and then it becomes the pulmonary arteries, okay? Okay. All right, let's see. What do you think? Is C. Yeah, right? If we're thinking right to left, so I said think right to left, brachiocephalic trunk. So we got the ace in the aorta, arch of the aorta, first thing, brachiocephalic trunk, which then goes to the right subclavian, right common carotid, on the left side, B, C, S, if you want to call that, alphabetical order, brachiocephalic trunk, left common carotid, left subclavian, okay? And bypass for the, remember where the foramen ovale is? It goes from the right atrium to the left atrium, right? So knowing that, what would it bypass? What's the function of it? It's supposed to bypass the pulmonary circulation, right? So lungs, and then what would the other thing it would bypass if we're not sending blood to the lungs? The right ventricle, right? It's gonna go directly from right side to the top of the left side, down and out, okay? That is it for today. It's a good stopping point. Tomorrow we're gonna talk all about electricity in the heart and the conductive system versus the contractile system. And then on Thursday, we will finish up with some stuff about EKG and some other various things. All right, any questions? All right, y'all.